So we start the next session now. Our next session will be an online session conducted by Dr. Tanu Singhal, and the topic for the same is, am I prescribing antibiotics rationally? So I request the delegates to please be seated as we are starting the next session now.
Hello, can you hear me?
Yeah, Tanu, we can hear you. You can start. Dr. Tanu Singhal is going to take this session from Varanasi. She is at the infectious disease conference at Varanasi.
So, a good afternoon to everyone, and I would really like to thank Dr. Chokhani for participating, for enabling my participation through the virtual route. So, when we talk about antibiotics, we know they are very used in children. In fact, this was the antibiotic prescription rate and pattern in the private sector. And if you look at this, the maximum number of antibiotics were prescribed in children below the age of 4 years, and the other antibiotics were prescribed for things like upper respiratory tract infections, cough, etc. So obviously there is a scope in improving rationality as far as prescribing antibiotics is concerned. And we will discuss this through various case scenarios, and I look forward to your participation in them. Now, let us come to this first case of a 3-year-old child who comes with high fever and sore throat. The nose is blocked and the child is snoring, and there is no previous history of snoring in this child. On examination, the tonsils are enlarged and congested, and there are some exudates, and there are multiple cervical lymph nodes which are not tender. So the question is that what antibiotic would you like to use in this setting? Comoxiclav, azithromycin, amoxicillin, or you will make your decision on the basis of a rapid streptococcal antigen test. Please vote. Okay, so I can see that most people have chosen option C, which is amoxicillin, and then we have a divide between using azithromycin and doing a streptococcal antigen test. Now, in my opinion, you giving amoxicillin is probably the best option. Um, and why is that so? Because we know that this is exudative pharyngitis, and 60% of this is likely to be streptococcal. Other differentials are adenovirus and EBV. Now, the only thing which is not fitting in with streptococcal pharyngitis is that there is snoring, which may tell you that even the adenoids have got enlarged. Now, in this patient, one must also look carefully for hepatosplenomegaly, because if you find a soft spleen, then you know that you may not be dealing with a streptococcal pharyngitis, but actually an infectious mononucleosis. Now, as far as doing a rapid antigen test is concerned, you can take help of the Centaur scoring system, in which you assign points to various types of findings. And if you look at our patient, we get a score of 4. Now, if you get a score of 4, then the risk of streptococcal pharyngitis is really high. And there you can just directly go ahead and give antibiotics, and you don't need to actually do the antigen test. You would like to do the antigen test in situations where you have an equivocal score to try and arbitrate between, giving antibiotics or withholding them. Now, one of the options was actually azithromycin, which is not the correct option because most of the the strep pyogenes are resistant. Now, this patient was started on amoxicillin, and 48 hours later, the fever continued. Now, at this point in time, we know that the antibiotic what will you do? Will you do a throat swab culture? Will you change to co-amoxiclav, or you would ask for certain investigations? Okay, so we actually have a kind of divided audience. There are some people who would like to do a throat swab culture. There are some who would change the antibiotic. There would some who would do a careful clinical examination, maybe to look for a liver or spleen which they missed earlier. And there, most number of people have opted for investigations, and I think that is the right answer. And apart from that, you must supplement it with doing a careful clinical examination. Now, in this case, one should not be doing a throat swab culture because the patient is already on antibiotics, so you are going to grow commensals. And we should also understand that if it is streptococcal pharyngitis that we are thinking about, it is universally susceptible to penicillin, and very rarely you may have failure of therapy if you due to production of beta lactamases by other throat bacteria. This is a patient where you should now entertain the possibility of infectious mononucleosis, and there are people who would say that if this was infectious mono, then the patient would have got rash with amoxicillin, but that doesn't happen always. So you should do a physical examination, and in this situation, ask for a complete blood count, look at the peripheral smear for atypical lymphocytes, and also do an EBV VCA IgM. The patient's EBV VCA IgM was positive, and antibiotics were stopped. And the main message in this case is that if your patient is not responding to properly chosen antibiotics, revisit the diagnosis rather than changing the antibiotics. So I think in the first setting, we were okay to start with amoxicillin, but when the patient did not respond, we should have thought of alternative diagnosis. Okay. Now come to the second case, which is a 3-year-old child who comes with fever, cough. Otoscopy shows a inflamed and bulging tympanic. Will you give start amoxicillin, or will you choose co-amoxiclav, or will you choose cefpodoxime, or just give symptomatic therapy with paracetamol or ibuprofen? And you can start voting now. Okay. Okay, so here most of the people have opted to start amoxicillin at 40 mg per kg per day, and there are some who want to give either co-amoxiclav or give symptomatic therapy. Now, in this situation, I think the best option is to give symptomatic therapy. This is a patient who has acute otitis media, and you can adopt a watchful waiting policy because this is a child who's more than 2 years old. He has unilateral disease and he has non severe disease. So these patients can be treated with paracetamol or ibuprofen, and you can watch for 48 hours. If you actually need to give antibiotics, then you need to cover for pneumococcus, Hib, and Moraxella. And in the first line antibiotic, we generally use amoxicillin at 40 mg per kg per day in 2 to 3 divided doses. Or if the patient is not responding to this, or if the patient has had previous history of AOM, or has very severe disease, you could choose co-amoxiclav. Now, another point to remember is that the middle ear is like a sanctuary site, and the penetration of antibiotics is poor. So, if you have a patient who's having recurrent episodes of otitis media, then you might want to use high dose amoxicillin at 80 to 90 mg per kg per day. There's another important message that either you don't treat these patients at all, or if you treat them, then give them for the right duration. Often you will see that you stop antibiotics after 5 days and these children come back. So, whereas you can get away by treating a pneumonia for 5 days, if it's otitis media, you may need to treat for longer times, and you give short term therapy only in older children. And this same policy applies to bacterial sinusitis. So if you have a setting of bacterial sinusitis and you are starting antibiotics, make sure to give them for 10 to 14 days. Otherwise, you will have a relapse. So we must remember that rational antimicrobial therapy is not just avoiding antibiotics, but if you're giving the antibiotics, then give them at the right dose and give them for the right time. Now, coming to the third case, this is of a 2-year-old boy who has fever and who's treated with zinc and ORS, which is appropriate. But by the third day, when the loose stools are not subsiding, then the patient is started on cefixime. And there is no response by day 5. And at this point in time, out of frustration, a stool routine is asked for, which shows cysts of Entamoeba histolytica and stool culture shows Candida. Now, in this situation, what will you do? Will you start fluconazole? Will you stop cefixime and concentrate on reducing lactose content in the diet? Will you start metronidazole and fluconazole because you want to cover EH and Candida? Or you will use the one of the common combinations in clinical practice, that is of Oflox and metronidazole. And you can start voting on this. Okay. So, if I see correctly, most people have gone for the right option, that is stopping antibiotics because it's most likely a viral diarrhea, and trying to reduce lactose content. But there are some people who have actually opted for starting metronidazole and fluconazole, which is not the right choice at all. So, when we talk about diarrhea, we must understand that diarrhea in children less than 5 years is usually viral, and there is no need for any antibiotics, and you just treat these patients with oral rehydration solution, zinc, antiemetics, and paracetamol. In fact, there's no role of probiotics either. And if you have to give antimicrobial therapy, that is in the setting of bloody diarrhea or diarrhea in a severely malnourished child where you give parenteral antibiotics or for cholera. Remember, there is no need for doing any stool routine or stool culture in patients with diarrhea. And if you find Entamoeba histolytica cysts, these actually indicate Entamoeba histolytica dispar, which is a non pathogenic Entamoeba present in the gut. Metronidazole is only indicated if you are seeing trophozoites in the stool or if you have given 2 antibiotics for Shigella, that is, let's say you choose cefixime or azithromycin and they fail. There is no point in doing stool cultures after a patient is on antibiotics and you will mainly grow very resistant pathogens. It is misleading. And remember that Candida is a very common colonizer in stool, urine, and sputum of patients who have been on antibiotics, and you must not use fluconazole for such infections. Now, coming to the third case, which is that of a 5-year-old child, and he has history of recurrent attacks of wheezing, and now he comes with fever and runny nose of 2 days duration and fast breathing. He's tachypnic, saturations are low, he has bilateral creps and wheeze. He gets better with bronchodilators, and oral steroids are also started because the saturations are low. But the pediatrician is worried, and they actually want to start antibiotics. So, what antibiotic will you give in such a setting? Because the child has fever, the child has tachypnea. So, as per the national guidelines, fever plus tachypnea is equal to antibiotics. So, will you use azithromycin, amoxiclav, cefpodoxime, or nothing? And you can start voting now. Okay, so I think the overwhelming majority has decided not to give any antibiotics, and this is actually a very enlightened audience, I must say. But I want to tell the people who have voted for giving some antibiotics that it is actually not indicated here, because this appears to be a viral triggered disease, and even if there is tachypnea, there is no indication for antibiotics. The investigation should not have been done because some of the people may or something which shows high counts, And because these patients may also have leukocytosis, and that is because of the stress response. And apart from giving antibiotics for a runny nose or a leaky gut, this is also a common indication where antibiotics are misused. And I showed you in that study which I presented the first time that a lot of patients received antibiotics for this reason. Now, moving to the fourth case, which is of a 7-year-old child who has fever and cough for 3 days along with mild tachypnea. And on examination, you find that there are right-sided creps in the intrascapular region, the right intrascapular region. So you are dealing with a case of pneumonia. So what antibiotic would you choose here? Would you give amoxicillin, co-amoxiclav for 3 days, or would you give cefixime? So you can start voting now, please. Okay, so I can see that there is like a kind of this between amoxiclav or azithromycin, and there are some people who have actually want to give cefixime, and the right answer, which is amoxicillin, is actually chosen by a minority. So let us understand why B, C, and D options are incorrect. Because when you're talking about a pneumonia in a child who is you know 7 years old, your most common pathogen is pneumococcus. Mycoplasma is not that common, and Hib. Now, if this child was below the age of 5 years, then yes, because you want to cover Hib and Moraxella, you could have chosen co-amoxiclav. Please do not use cefixime for any respiratory infection because it doesn't cover pneumococcus at all. And even the third generation cephalosporins like cefpodoxime, cefdinir, cefprozil are not good. And remember that if you choose azithromycin, because a lot of the pneumococci are resistant, so that is why the right antibiotic to give in this setting is amoxicillin. Now, another common situation, a 6-year-old with fever for 2 days with no focus. The CBC is normal and malaria is negative. The typhi.IgM is positive. So, which antibiotic would you like to use in this setting? Would you use cefixime? Would you give azithromycin? Or you would give a combination of Oflox and cefixime? Or you would give no antibiotic at all? And you can start voting now.
Tanu, your voice is cracking. So people are suggesting that you can switch your video off and talk because there's a signal issue. And you have about 7
Okay.
8 minutes left. Thank you.
I hope this is better. So actually, most people have opted for the right option, which is basically to give no antibiotic, because this is still, it could be an undifferentiated fever, where viral fever, and in such a situation, one should actually not do any investigations. If you have done a CBC, please look at the monocyte count, because I find that really useful in clinical practice and as a pointer to a viral infection. Typhoid.IgM has very high false positivity rates, and it is better to treat these patients symptomatically. And if after 3 or 4 days, if the patient is not better, send blood cultures and start antibiotics which are appropriate for enteric fever. Now, coming to the next case, which is a 2-year-old with fever and mild runny nose and cough, whose urine routine shows 5 to 6 pus cells, and the leukocyte esterase is positive and nitrite is negative. Now, in this situation, what antibiotic would you like to give the patient? And your time starts now. Would you give coamoxiclav or would you give cefixime, which is antibiotic, give okay. Yes, so I think most people have given chosen the right option, which is no antibiotic, because remember that this patient has clinical features of an upper respiratory tract infection. In this situation, one must not have done a urine routine at all. Have mild pyuria in any patient with fever. But if you have a situation where you indeed have a UTI, like fever with no focus, then send urine cultures and cover empirically for E. coli, and your choice could include coamoxiclav, cefixime, ceflexin, or cotrimoxazole. And you must send urine cultures before starting antibiotics because you're seeing a lot of ESBL infections even in the community. So I think I will skip this case and go to the next case. So this is basically again a patient who had received coamoxiclav 1 month ago for a URTI, comes with and the oral capillary filling time, and so this patient is admitted. So what antibiotic would you choose here? Would you give ceftriaxone? Would you give ceftriaxone and amikacin? Would you give piperacillin tazobactam, or would you choose IV coamoxiclav here in a case of a complicated? And your time starts now. Okay, so here most of the people have actually opted for ceftriaxone, and I will discuss why that is not the right answer. Because this is a febrile UTI. This patient has also got antibiotics earlier, which increases the risk of ESBL. The patient seems to be in early septic shock. So you must hit with the right antibiotic to begin with to cover ESBL UTI, and therefore PIPS is justified, and optimize or de-escalate once your cultures come back. And it is very important in this patient to send cultures before the first dose of the antibiotic, even if it means to do a single time catheterization. So remember this, that you're also doing the patient harm. Conclude by saying that most infections in children are viral and do not need antibiotics. And these include URTI, diarrhea, and these associated infections, because otherwise they will go hunting for antibiotics elsewhere. Along with treatment, not send investigations when not needed. Like in that patient with URI, we sent a urine routine. In that patient with diarrhea, we sent a stool routine and stool culture. And once the results come back, you must interpret them carefully to this result you got. Does it really merit treatment? Like that case of typhoid where the typhoid.IgM was positive. If an antibiotic is necessary, then choose carefully and stop antibiotics if an alternative diagnosis is made. Because sometimes people believe that you have started an antibiotic, you have to complete the course. That is only where you have made the diagnosis of a bacterial infection. If your patient is not responding to antibiotics, revisit the diagnosis instead of changing the antibiotic. And also, giving so it should read that giving a lower level antibiotic when a higher level antibiotic is needed, or stopping therapy early, is also irrational therapy. So while under treatment, over treatment is irrational, even under treatment is irrational. Thank you so much.
Thank you so much, Tanu madam, for joining us online. With this, we now move on with our next session, which is case scenarios in nephrology. For this, may I invite Dr. Pankaj Deshpande and Dr. Amruta Baviskar for the session.